Welcome to Healthy Liver, Healthy Life, a special podcast series where we speak to leading experts about liver health and advancements in treatment. Consultant medical oncologist, Hemato Oncologist and BMT Physician from Bengaluru to discuss hepatocellular carcinoma. Thank you for joining us.
Hi
Dr.
Gayatri,
Rajeev.
pleasure to see you.
So, I want to start by asking you, how has the global incidence of hepatocellular carcinoma changed in recent years?
So basically hepatocellular carcinoma, that is actually a cancer of the liver. During my MBBS days in the early 2000s, so we used to just hear of these cancers. At that point of time, I'm sure all of you have heard of hepatitis B. Now it's there in the national immunization schedule itself.
Yeah.
So we give it to the small babies. Earlier in the day, it used to be given to adults because none of us knew about it. The doctors, nurses, while giving injections, syringes, surgeries, would get infected and then end up having jaundice and cirrhosis. Cirrhosis means shrinkage of the liver. And then this around 95% of the people who develop hepatitis B infections would seroconvert. That means the infection would go away. In 5% it would remain. And then in that 5%, around 10% would develop cirrhosis, that is shrinkage of the thing. And in the people who develop cirrhosis, a sizable number would develop liver cancer. So that was called hepatocellular carcinoma. So prior to the 1990s, it was almost an unknown entity where we did know about it, but we didn't know how to treat it. Neither did we know how it occurred. Then we realized it is hepatitis B. Then with time, we started realizing there is another infection called hepatitis C also, which causes it. So mainly we thought hepatocellular carcinoma means it is caused by either hepatitis B infection or hepatitis C. So this was in the 1990s and early 2000s. Then with time, we started realizing that a lot of patients who did not have hepatitis B or hepatitis C infection, even they were developing cirrhosis and liver cancer, hepatocellular carcinoma. Of course, then the age-old problem of alcohol was there. So alcoholic cirrhosis, hepatocellular carcinoma. Then we realized that people who are teetotalers, don't have any hepatitis B or hepatitis C, no alcohol, they were developing liver cancers. So and then comes the question that where is this coming from? What is happening?
What's causing it?
Then we started noticing they had fatty liver, or we used to call this non-alcoholic fatty liver disease, NAFLD, or we used to also call it NASH. There was an American series called NASH in the past as well. This is non-alcoholic steatohepatitis, basically fatty liver, the technical terminology. So with time we realized in the recent past, now in the rest of the world, especially in the Africas, 80% or 90% is hepatitis C and hepatitis B driven. In the Americas, it is around 70-75% is hepatitis HPSH or HCV positive. Rest of it is fatty liver. In India, contrary to what we've all known, 55-60% is due to fatty liver. Now, every time you go for a health check, you will get a thing and then the doctor says, oh, you have fatty liver, nothing will happen, go. It's important that you take care of it at that point in time, get going with your regular exercises and do your regular yoga, meditation. Why? Can that be prevented there? Yes, it can be prevented over there. The fatty liver, it becomes from grade 1, grade 2, grade 3 and then becomes into cirrhosis. If you're able to stem it at grade 1 and grade 2 itself, then afterwards you're doing yourself a good favor, big favor actually.
Yeah.
So that's the thing. So earlier it used to be mainly hepatitis B driven. Now we have array of different etiologies or reasons as to why one would develop hepatocellular carcinoma or liver cancer. Okay, like I've
So we mentioned that alcohol and fatty
alcohol,
liver.
fatty liver, hepatitis B and hepatitis C. And there are certain other toxins which we are yet unaware, like how we have been learning over the last 20 years as to what are the different reasons due to which hepatitis or hepatocellular carcinoma is caused. Similarly, there are some things called aflatoxins. And something very important, we put this big bucket of fatty liver. Now you should ask me, doctor, what causes fatty liver?
Yeah.
Fatty liver, unfortunately, is caused by a large amount of trans fats in our diet. Next time you buy any processed food, it could be a packet of chips, it could be anything like cheese or anything that has oil, fried or your juices, look at what is the percentage of trans fat, TRANS fat in that. It will be given in the ingredients.
Yeah.
So when you start looking at that, you'll start realizing that you're consuming so much of trans fats. And now trans fats is basically, it's like which are processed fats. Like right from all the fries that you buy in your fast food outlets, whichever are so tasty, nice, all of them are loaded with trans fats. So especially when you buy your ice creams as well. So you should see which of them are actually ice creams. We know that there are some of them which are made only through milk, the original ice creams, and some of them are like, they're like only like the proprietary dietary food, or the frozen desserts, we call them. They're filled with trans fats. All of these, your daldas, your palmolines, all of them filled with that. So when your ice creams are made of that, your food is made of that, your food is fried in any of those entities, you're consuming loads and loads of trans fats. That gets, poor thing, the liver is unable to metabolize it, because liver can metabolize anything that is natural. Anything that is processed, liver doesn't know what to do about it. Like plastic is also processed, comes from the petroleum industry. It's processed, so therefore nature struggles to break it down. So something akin to that. So therefore this is something that I'd like our viewers to know, that trans fat in any kind of food that you consume, know what you eat. Very, very essential. So if you're able to do that, and more importantly, do a lot of exercise, keep yourself fit, it's very, very essential. So the populations, people who consume alcohol, and when you're consuming alcohol, what else do you do? There's one side, chips. Smoking. So a combination of alcohol, smoking, and then snacking is a beautiful, deadly combination. So my friends at the club and at the bar are going to be very, very angry with me for saying this, but that's the truth, my dear friends. When you have a combination of all of these three, it's a pure cocktail, to say, to develop fatty liver, and hence, and then some people, people with unprotected intercourse, they can develop hepatitis B or hepatitis C. So for the population where it's an economical part, where they go to a barber who charges less, ensure that the blade is changed. Do not use the previous blade. Any cancer for that matter, once you have, it progresses into a much more bigger stage, like you have stage 1, 2, 3 and 4, becomes bigger, the menace is bigger. It's similar to having terrorism. If you're able to stem the terrorism at its, nip it at its bud, it doesn't become into an organization. You leave it, it becomes into a humongous monster. Here too it's the same, because the tumor would develop methods to spread its tentacles and wings to different organ systems. Then afterwards, then the main plot is lost at that point in time. So then afterwards you will have to do firefighting. So it's better for us, prevention is better than cure. And when you identify it in the initial stage, stem the rot. You go to the health check. When you go to the health check, we get a liver function test done. So we start in early fatty liver and in cirrhosis, you start noticing that the enzymes start going up. There might be a slight increase in the bilirubin. These things could happen. Then afterwards, when you get your ultrasound abdomen done, they look at the liver, and the liver can have grade 1 fatty liver. Once this kicks in, you need to be very careful. Then you'll be sent to your physician or your gastroenterologist or hepatologist. They will do something called fibroscan. Fibroscan is just to know how supple the liver is. So the normal liver is very supple. When the more amount of fat that gets accrued into it, it becomes much more firmer. So therefore and then subsequently there's a lot of inflammation that keeps going on, then becomes hard. So this spectrum that is there, you need to stop it then and there. So therefore, for that, fibroscan is needed, is useful. You can also get an MRI of the liver done, a CT scan of the liver done, and in situations we can even get a PET CT scan done. There are certain blood tests like alpha fetoprotein, but that is not to be done as a routine, only when an imaging picks up a particular lesion. Otherwise, it'll become very confusing for the patient as well as for the doctor. So like I said, ultrasound, MRI, CT scan, and a blood test, alpha fetoprotein. These can be done in appropriate patients. Patients who are at high risk, who've had hepatitis B infection, who've had are suffering from hepatitis C infection, these people should be very regularly screened once every 6 months. And for the rest of us, once in a year or once in 2 years should be sufficient.
Just for a regular checkup?
Regular checkup.
Okay.
And if you are symptomatic, please go and show your doctor.
Okay.
Okay, if you are, now we have two scenarios. You are in Bharat and you are in the rest of the world. If you see a doctor, your ultrasound appointment will be in the next 30 minutes to an hour. So that's the speed. So the whole world is now coming to India to get their root canals done as well. And for even regular health checks, a lot of people come from Middle East, from Africas to get a regular health check done. And they even come from Bangladesh and neighboring countries. They come from Sri Lanka, get the health check done, and then they go back. And very easily available. If you are a citizen of Bharat, you are in the most or in the best situation in the entire history of Bharat right now. Everything is available in abundance. So
Definitely.
it is just probably a walk across the park and you will find your center. Okay, so then now let's consider a patient comes to me, says that, sir, I've gone to a physician. He's found I was doing a routine health checkup, or he might have jaundice. Scan is done, and then afterwards there is a lesion in the liver. So when they come to us, so we sent for this thing that I told, the tumor marker called alpha fetoprotein. There is another marker called PIVKA, P-I-V-K-K-A. So this is another blood test. These two blood tests are, if it comes high, it is sine qua non or diagnostic of a hepatocellular carcinoma. So if either of these or a combination, we use a particular algorithm for that. If it comes high, it is classical of hepatocellular carcinoma, wherein you don't even need to do a biopsy. So an imaging, we would, and then after these couple of blood markers, biomarkers would help us. Now we've gone to a different level also. After this, this would tell us about the diagnosis. Now coming to the therapy. So what we do is that when required, we take a biopsy from that tumor, or we can even do a liquid biopsy. That is from the peripheral blood, a regular blood sample. We search for the circulating tumor cells. All of this, when I'm telling this, right now the gold standard is tissue, but we are using liquid biopsy or peripheral blood to identify what are the different mutations, and we are able to give personalized precision medicine or precision oncology for our patients. We are able to identify typically which drug would work and which drug would not work. And this is not written in stone, but it gives us a good direction as to what therapy would suit the patient best. So like I mentioned, we have the alpha fetoprotein, we have the PIVKA, and then afterwards then we have the peripheral blood circulating tumor cells which are isolated, or the circulating tumor DNA which are isolated, and we look for particular genetic signatures in them. So if these genetic signatures are there, then it is sine qua non of hepatocellular carcinoma. It also gives us the therapeutic cascade as to what are the therapy options. It opens up like a menu card. You see that these are the different mutations, these are the therapies which are going to work, this may, and these therapies may not work. So in our menu card of therapies which we normally have, conventional therapies, we are able to pick and choose. Okay, this will work. This may not work, use this.
Okay.
Like I said, we have 4 stages of hepatocellular carcinoma. We have stage 1, where it's localized. Then we use basically the BCLC staging, or the Barcelona clinic. Then afterwards, we also look at the background of the tumor, and this of the liver. What is the amount of, we call this Child's Pugh Turcotte staging or scoring system. So we look at the size of the tumor, we look at the background of the liver as well. And with this, if it is localized, you will try to offer surgery if you can remove it. So in the early stages, you will try to offer surgery. If it is in the center, where between both the lobes, you can't offer surgery, you will try to see whether you can use something called TACE or TARE, that is transarterial chemoembolization. You go into the tumor, give chemotherapy inside the tumor, shrink it. Or you give some radioactive elements inside. So that's called TARE.
These can only be done in early stages.
Early stages or slightly mid stages, you will be able to do that. Once it crosses this particular stage, either you do surgery or you do TACE or TARE, and suppose it becomes metastatic, it becomes stage 4, that is fluid in the abdomen, or it's gone to a bone or to a lung or any other organ system, then offering local therapy will provide some respite from pain, swelling, etc. But it will not cure the disease. At that point of time, the new big boys and the new toys which we have, the immunotherapy drugs, they have now kicked in. So they don't offer cure, but they definitely control the disease to a very, very, very large extent. So we have these immunotherapies, basically are drugs which are given through the IV line, gets into the system. It's a half an hour infusion to an hour infusion. It potentiates the body's own immune system to seek and kill the cancer cell. Immunotherapy is like making your policeman strong. He becomes the Singham. So where he goes there, you empower him with all the energy to seek and kill the criminals. So that's what our immunotherapy does. It potentiates the body's own Singham police to ensure that it is able to identify and kill the tumor cells. So that, along with that, we also give certain drugs to cut down the blood supply to the tumor. So you cut down the, like in a terrorist organization, you have police to go and kill, or the army to go kill the terrorist. You also freeze their bank supplies. So it's like freeze their bank accounts. So therefore, they don't get the money. So the foreign funding, whatever comes, is frozen. So similarly, what we do is we give blood medicines which will go cut down the blood supply to the tumor. So it is starved of blood and oxygen and energy. Then you give some immunotherapies which will go there and seek and kill those tumors. So therefore, you're able to reduce it to a large extent. So in hepatocellular carcinoma, we also use something called radio frequency ablation, where we just use our microwave ablation. The same microwave that we have, it's available in the form of a probe. You just go there and then bzzz, it burns it off. We use all of these. So typically for a patient with hepatocellular carcinoma, if you come to our institute or any institute of repute, you will find a medical oncologist like me who is trained in immunotherapies, chemotherapies, targeted therapies. Then you will find a surgical oncologist or a surgical team who are going to operate on the liver as and when feasible. You will find an intervention radiologist team who are going to do the stays and tear. They're going to go into the tumor and supply the chemotherapy inside the tumor. You will find a radiation oncologist who will help in giving radiation. We call that SBRT, to just burn off those tumors using X-ray beams. So, and which patient needs what? It is a mix and match of all of these. So the patient would need either of our services at some point of time during the journey. So it is a multidisciplinary tumor board that we would conduct for each patient and then decide. And we would keep meeting up on regular intervals for that particular patient to say that, you know what, the patient's done well, use this. You know what, the patient has had a problem now, I will utilize his. It is like a cricket match. So your Harbhajan Singh is as important as your Sachin Tendulkar. So either for bowling or for coming in the last overs and belting sixes. There are the prognostic models, like I told you, like we use the BCLC staging system. Then we use the Child's Pug Turcotte, the scoring system, to know what is the health of the liver. If the liver is very in bad shape, then we say that, you know what, we will only give you best supportive care. In these kind of situations, when in bad shape and if the disease is not spread elsewhere, then the transplant team comes into play. They would say that, you know what, there's no disease elsewhere, it's there only in the liver. Let me pull it out and put in a fresh liver, either from a cadaver donor or from a living donor. So we would give our therapies, curtail the disease. Then the transplant surgeon comes in, pulls out the tumor, places in a fresh, non-infected or a non-diseased liver. Like I mentioned, we have our immunotherapies, we have our drugs to cut down the blood supply, like bevacizumab. Then we have some regimens where you use both double immunotherapies. It's like you give potentiation to the polis as well as to the CRPF. So both of the guys go and kill. Not just severe, it's like we choose depending on the comorbidities, the level of the liver, whether having any bleeding chances. Some patients have piles or gastric ulcers, have a propensity to bleed. So those patients, we can't give certain drugs. Like I mentioned, the drugs which cut off the blood supply, doing that might actually hamper the other problems of the patient. So then after we have tablets. Prior to these immunotherapies which came in, the last 10 years we were treating with only oral tablets. that would give the patient around at least a year and a half of survival. In the previous era, when nothing was available, patients would die in 3 months. So now with the tablets, it went up to around a year and a half. And then with the immunotherapies, advent of immunotherapies, it's surpassed 2 to 3 years in many patients. And now that we're doing multitude of all of these therapies, intervention radiology, where you do TACE, then you do TARE, microwave ablation, radiofrequency ablation, then afterwards offer surgery, offer radiation, offer immunotherapy, offer tablets. It has to be taken as a team. So, like I mentioned, the longevity has improved, the toxicity has reduced, quality of life is so fantastic. Many patients carry on playing golf, carry on doing their work. We are using the immunotherapy to downsize the tumor stage and then offer more curative therapies. And if it is already spread out, then we give the immunotherapies to cut down the tumor size, cut down the spread out disease, and so the effect on the other organ systems like the lung or the intestine or any other organ system, that is reduced. So therefore these patients have less symptoms, carry on with a near normal life. They just think like, oh yeah, it's a liver cancer, it's okay. Well, I'm enjoying my food, I'm enjoying my regular trips, traveling, I'm getting back to office, I'm taking care of my family. So rather than keep it at the center of their life, earlier a patient with the cancer, you'd be like, oh, I'm a cancer patient. Wherever you go, to go here, I'm a cancer patient. Now it's gone. It's like, they're like, yeah, I am who I am. This is my profession. I do all this. Yeah, by the way, I also have a cancer, which is being well managed by my oncologist. Okay. So that's how the viewpoint has changed. Yeah. That's how we want it to be changed for the rest of Bharat and the rest of the world as well. In the sense that because we are there, we started doing it. Our patients started enjoying near normal lifestyles with these therapies. Yeah. So at present, the costs were very prohibitive. But thanks to the earlier, what happened is that there are only one or two companies which made the drugs. Now there are multitude of companies which are making the drugs. We're also in the near future, we're going to have a lot of Indian generics, or technically called biosimilars, because these are all biological agents which are entering into the market. So therefore the costs will come down. But even the present day, the MNCs which are actually providing the drugs, they come with a very good patient assistance program. That is, you buy a certain amount of drugs for a certain period of time, then they assist you financially. Based on the patient's financial status, they give more extra discounts. So this will make it more useful to the public and more accessible to all our citizens. Rajeev Vijayakumar.